evening, everyone. I welcome you all for today's webinar on updates in the management of breast and lung cancer 2022. And with immense pleasure, I would like to invite Dr. Trivikram Rao, who is consultant medical oncologist at American Oncology Institute, HISAR, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
So thank you, Mrs. Ekta and the team and Tarun and all. So thank you for organizing this event and good evening, all my seniors, colleagues and friends. So I welcome you all for today's academic feast. And as we all know, oncology is rapidly advancing at a rapid pace, and our motto is to learn and update our knowledge regarding newer updates in the management of cancer. So which helps in the betterment of management of our patients. So with the same view, we have planned for today's webinar, which is on newer updates on breast and lung cancer. So I'm happy to once again welcome you all the eminent speakers for today's program. And without much delay, I welcome our first speaker, Ms. Aparna, Dr. Aparna Dhar, Head of Department, Medical Genomics and Genetic Counseling, Fortis Memorial Research Institute, Gurgaon. Over to you, ma'am.
All right, good evening, everybody. Just very quickly going to share my slide. All right, can we see my slides?
Yes, they're visible.
All right, perfect. All right, good evening, everyone, and thank you very much for having me here today and giving me the task, for the next 20 odd minutes to walk you through essentially the molecular landscape of breast cancer. So let's get started. So we know patients with breast cancer, we have a very simplistic way of classifying them. The classification is based on the ER/PR HER2/neu. Is on the ER/PR HER2/neu status, and we know the triple negative breast cancer constitutes for around 15%, where chemotherapy is the treatment option. Then you've got your HR positive disease, which constitutes for around 70% of our patients, and hormone therapy is the mainstay of treatment. And then around 15% are those HER2 positive, where HER2 therapy, does improve significantly the prognostic outcome and in both advanced and in early stages. So we've actually moved beyond this if you think about these intrinsic subtypes such as your luminal A HER2 positives and your basal-like subtypes. And we're now looking at, for more genomic drivers, we're looking at alterations in the PI3K pathway, we're looking at DNA repair genes, resistance mechanisms in the ER signaling pathway, and more growth factor receptors like your FGFR1, which could potentially, allow us to have more targets that can allow us to personalize treatment strategies in patients with breast cancer. And this is specifically important in patients with metastatic disease, with metastatic breast cancer, where the genetic landscape is very heterogeneous. And as you can see on this very busy slide over here, that within each subtype, the HR positive, the triple negative, you have a plethora of different somatic mutations that can occur. So if you look at the differences between early and metastatic, you can see that there are at least 9 driver mutations. You've got your TP53s, your ASR1s, your AKT, and which are more frequently mutated in the ER positive, metastatic versus the early ones. And then similarly, if you look at our triple negative breast cancers, we are seeing an increase in the frequency of somatic biallelic loss in those homologous recombination repair genes. And the tumor burden and the clonal diversity is far more higher and far more complicated in your metastatic breast cancer versus those early breast cancers. So if we actually, if we actually look at this, when we know the ER/PR HER2 status, so what we're essentially now doing is we're going beyond these targeted therapies, and with the help of diagnostic platforms like next generation sequencing, MLPA if it's germline, we were able to determine somatic aberrations or germline mutations, which in turn helps us guide, helps guide treatment options. And this is again a very simplistic view of breast cancer. And this algorithm essentially alludes to the fact that you have 3 biomarkers. You have the ER/PR and HER2/neu. It makes a couple of assumptions. One assumption is that these biomarkers are static, and we know that patients the patient's tumor when it recurs, or when you have a patient with stage 4 de novo, on progression, in about 30% of these cases, these biomarkers do not stay static, especially your HER2. Another assumption it makes is that there's only one pathway, and that's dominant. That's that one pathway which is dominant. And I'm again going to show you that we really need to see those different pathways that are activated when it comes to treating our patients. So a very, very simplistic view. I'm not an oncologist. I'm a molecular geneticist and oncogeneticist. So it's slightly different. This is what metastatic triple negative breast cancer looks like. You put the patient on chemotherapy as your treatment option of choice, and you see the PFS decreases with each line of treatment. Now, if I look at the tumor biology of triple negative breast cancer patients, we know that they're typically associated with the worst prognostic outcome. And as you can see from this heat map here, patients with triple negative breast cancer, it isn't as simple as we really think it is. So even in this group of patients, if we see subtypes like luminal AR, the mesenchymal basal immune suppressed, those basal immune activated, and among each of these subtypes, we have different treatment strategies. So you've got immunotherapy for basal immune activated. You've got PARP inhibitors for those with alterations in the DNA damage repair pathway. You've got immunotherapy combinations in your basal immune suppressed subtype. And of course, you've got that anti-androgen therapy in your luminal AR. So it's really not very simplistic. So what does the molecular landscape look like for a triple negative breast cancer patient? So essentially, if we profile an advanced or metastatic breast cancer case, you could get an alteration in any one of these pathways. We know the DNA damage repair pathway, PARP and platinum has a very clear role. If we look at those inflamed phenotypes, which is essentially your PD-L1s, your TMBs, your MSI, those signatures, immunotherapy has a very clear role to play. Androgen receptor, if positive, we have agents or creations in the big 3CA, we have AKT inhibitors. And last but definitely not the least, there's agnostic markers like NTRK fusions, RET, which does have orphan drug status, and re-looking at that HER2. And just to give you a flavor as to what I've used to kind of build my algorithm over here. Now, we know triple negative breast cancer patients with a germline, a hereditary BRCA mutation that's been called out using NGS and MLPA. Don't forget MLPA in germline testing. We've got the Olympiad and BRCA trials that alluded to the fact that those patients who had a mutation in their BRCA and a PARP inhibitor was given, you see a very nice separation in these Kaplan-Meier curves that are favoring the group of patients who received a PARP inhibitor. And this is very interesting data from a phase 2 trial where triple negative breast cancer patients received a combination of chemotherapy in the form of paclitaxel and capivasertib. Capivasertib is a target for the PI3K pathway. It's an AKT inhibitor. And what you saw was an alteration in the tumor. We saw where there was an alteration in the tumor, the really nice separation of the Kaplan-Meier curves favoring the patients who got this combination of capivasertib with paclitaxel versus those tumors that did not have an alteration in the pathway. And then you have your HR, your hormone receptor positive, which is ERPR positive, HER2 negative subtype. And these patients not only have ERPR as potential biomarkers, but we actually need to look at different pathways, such as where you can acquire an ESR1 mutation. And we know that agents like aromatase inhibitors, they don't work as well. And we need to look at agents such as, fulvestrant. So again, HR positive, there can be defects in the DNA damage repair pathway. With PARP inhibitors, we get this from the Olympiad trials, can work. And if you look into that AKT pathway, and of course, you've got those agnostic markers and reassessing HER2. So in this particular cohort of patients, your HR positive patients, for me, I think the tumor biology of the disease is very important. And I think we should be doing this upfront. And the reason being is that patients do acquire endocrine resistance. And you can see in this very nice animation that we have over here, that even those patients, on who we have given hormonal therapy, at the beginning may have a very small percentage of endocrine resistance already present. It would be there up front. And what eventually happens is when they put on hormonal therapy, about 18% of these acquire an ESR1 mutation. Around 13% have some sort of a defect in the MAP kinase pathway. Around 9% of these patients have mutations in the MYC pathway. And these acquired genomic alterations will eventually lead to endocrine resistance. So the question that follows is, could these evolutionary tracks eventually, influence the choice of subsequent therapy? And the simple answer is absolutely yes. And that's why upfront looking out for the tumor biology becomes very important. And for this particular mechanism in this, HR positive, I like, kind of using this triangle to emphasize the three most important, the three angles, the three nodes in this HR positive signaling network. On one hand, you have your estrogen receptor, and on the other hand, you have your CDK4/6, and up there, you've got your PI3K pathway. So whatever you do in an ER positive breast cancer patient with one of these angles, with one of these nodes, one of the signaling nodes in this triangle, if you block one, the other two get activated. So if you try to block, let's say, ER, the PI3K and the CDK4/6 act up. If you block CDK4/6 and ER, the tumor escapes through the PI3K pathway. So if you try to block PI3K on its own, the ER signaling goes up. And that's why, it really isn't advisable to give PIK3CA inhibitors as a single agent, because you have this adaptive increase in the other components of this triangle. And this triangle actually also shows you a new age of clinical trials now. After developing various doublets, whether it's endocrine therapy with CDK or hormonal therapy and PIK3CA or mTOR, the new wave of clinical trials is actually focused on developing regimens at the same time that target these three triangles, these three nodes. So I just thought it was very interesting work happening here. So in the somatic mutations, we know there is a difference between early and advanced metastatic breast cancer, especially in the ER positive subtype. And there's a very interesting development that has been, the identification of tumors acquiring ApoBec signatures in high TMB and ER positive subtypes. Is it a potential target? Well, this was a very nice, to answer that question, this was an excellent study, if you ask me, that was presented at ASCO a couple of years ago. So this particular patient was ER positive breast cancer in 2001, got the appropriate treatment that we give for early breast cancer, and eventually there was a recurrence in 2010. After multiple lines of therapy in 2015, an ApoBec high signature was reported, and eventually the patient was started on a combination of immunotherapy, which is pembrolizumab here, and physician's choice chemotherapy, and the patient did have a good response, very promising area. And then results from the SOLO-1 trial, where we had the HR positive, HER2 negative metastatic breast cancer patients with a PIK3CA mutation, a combination of PIK3CA with fulvestrant, so a very good response versus the wild type group. And in addition to this, what was very important was that irrespective if the mutation was called out on a tissue or a liquid, the efficacy was the same. But interestingly enough, the propensity for calling out these mutations were higher in liquid biopsy versus a tissue biopsy. And I've said this before, that one can acquire a HER2 mutation. And in this phase 2 Summit trial, it looked at patients with HR positive HER2 mutant, and these were again heavily pretreated. So in this case, they gave them a combination of neratinib with fulvestrant, and this combination resulted in a clinical benefit rate of around 47% and a PFS around 5.4 months. Not bad. I do know there are reservations around this, but sometimes something better than nothing. And this is just a more personalized approach where we are factoring in the whole endocrine. This is how we actually treat them in our clinics today. So. With the flavor of season being PARP inhibitors, I very quickly want to draw your attention to a very important concept called BRCA reversion, and especially in our heavily pretreated cases. And interestingly, I've actually seen this across the board with breast, ovarian, pancreatic, and prostate cancers. So it becomes extremely important to call it out in these, in such sessions. So what is BRCA reversion? Now, essentially, it's a phenomenon whereby the BRCA alteration has the potential to restore their reading frames and revert to their wild type sequence, or remove an initial deleterious alteration and restore at least partial BRCA function. And interestingly enough, BRCA2 is far more susceptible to this. Now, this is a very nice case study to illustrate this concept of an ER positive breast cancer patient, progressed on multiple lines of therapy. They did testing, they found a BRCA mutation. She was started on the PARP inhibitor. She had a PFS of around 8 months. Chemotherapy was added. She continued to progress. They did a liquid biopsy at this point, and they called out a BRCA reversion. And ESMO's actually come out, with the scale for action, for clinically actionability of molecular targets, especially in breast cancer. And as you can see, the level 1 and level 2 evidence tends to be in terms of looking for HER2 amplifications, your germline BRCA mutations, PIK3CA, MSI, NTRK, there's agnostic markers, ESR1s, which you acquire over time, PTEN loss, and AKT mutations. In addition to this, there are all these other mutations that are here. While they may not have therapeutic implications or they may be in clinical trials, they help us understand the tumor biology and actually make informed therapeutic decisions for our patients. Now, another very important factor that I want to highlight is that we know heterogeneity, both inter and intra-tumoral, does cause a problem when you're trying to trace those biomarkers in your patients. And one way to look at that, the genomic landscape of your patient's tumor, is actually using liquid biopsy, where you isolate the ctDNA, circulating tumor DNA. And this is essentially the somatic, the tumor DNA, which is discarded when the cancer cell breaks. It releases the somatic lysis. It releases this somatic tumor DNA into the bloodstream, which gets isolated and is studied. We do have circulating tumor cells, which is essentially the intact cell that's just, that's circulating in our bloodstream. Due to paucity of time, I'm not going to be talking about it, but there's a lot of amazing work happening in that area, especially in the realm of breast cancer. So how does liquid biopsy help us in our clinic? One of its key distinguishing factors from tissue biopsy is that because it's non-invasive, it can help you detect those resistance mechanisms. And there are two particular mechanisms I'm looking at. One is by looking at the linear clonal evolution, which basically involves tumor cells where you have a temporal evolution where one dominant clone, you lose the dominant clone, and the less dominant clone becomes dominant over time, which is selected out by therapy. And the third one is branch clonal evolution, where you have spatial evolution in terms of divergence of different clones that happen. And what you essentially get is a mixture of different cancer cells resulting in resistance. And one of the key questions we tend to ask ourselves is, what is the clinical utility and the benefit of looking at ctDNA in metastatic disease versus just profiling a tumor? I know I get this question in my clinic very often. And this was one of the key objectives of this mirror study. And what they did was that they evaluated the concordance, first of all, of genomic variants between the primary tumor tissue and the ctDNA in patients with metastatic breast cancer. And what they reported was that there was a 97.2% concordance between the two. Interestingly enough, the 13 variants in metastatic tissue and ctDNA obviously were not present in primary tumor, because we know that when a tumor progresses, the heterogeneity increases. And ctDNA could actually be used to detect these alterations in patients in metastatic breast cancer. There was another very important point, that there was a certain percentage, and I can't remember right now, where circulating tumor DNA was able to call out mutations, which even the metastatic tumor was missing out, and that was because of heterogeneity. And here's another fantastic study of the plasma match trial. And the key objective was to report the response, or complete or partial, to match therapy, that was one part of it. The second objective, was to actually analyze the genomic alteration frequencies and to see what was the agreement between Ddpcr and NGS and its concordance of tissue biopsy and ctDNA. And if you actually look at this, while we do know that in these metastatic settings, ctDNA liquid biopsy did fare a little bit better, it was not inferior to tissue biopsy. And if I do a head-on-head comparison of Ddpcr versus liquid biopsy on NGS, the liquid biopsy using NGS had a higher propensity for calling out mutation versus Ddpcr. So even on a liquid biopsy head-on-head, the NGS version actually proved to be far more accurate and came out reporting, more mutations that are, it has a sensitivity of around 98%. And if you do a combination of both the liquid biopsies with Ddpcr and NGS, it was around 93% sensitivity. It further cemented the fact that liquid biopsies could be used to call out these actionable variants. And another very pertinent question is, could you detect these driver mutations for treatment of resistance mechanisms early using tissue? So this is a very nice case that was presented by Dr. Chandrila Bhatti from the Memorial Sloan Kettering group, of an ER-positive patient, invasive ductal carcinoma, and I'm just going to focus on the ESR1. Now, when they did tumor testing in February, they weren't able to detect an ESR1, and then the ESR1 was detected in July in 2015. Interestingly enough, when they did a cfDNA in 2015 Feb, same time as the first tumor testing, they were able to call out that ESR1 mutation, which takes me back to that animation where I said, you do start your patient on hormonal therapy, but that resistance gene, the resistant clone is lurking in the background, and liquid biopsy is a very good platform for calling it out. And this was a study where they looked at 4,400 patients that underwent a liquid biopsy. This was, I think, using the Guardant, if memory serves me right. And the genomics landscape looked something like this, where we've got around 55% TP53, PIK3C coming in second at 35%, your ESR1s, your PTEN. And this landscape, this genomic landscape looks very similar to when we do tissue testing. Again, showing that if you don't have tissue as an option, you can't do a rebiopsy, or if your tissue comes negative, I would very strongly urge you, if finances are not an issue, to try and do a liquid biopsy. And yeah, this was another great paper that was presented of ctDNA and tissue testing done up front, and tissue DNA had a tissue biopsy had a 66% actionable mutations. It was able to call that out versus the 84% from ctDNA. So ctDNA again showed, it was not inferior. That's a more diplomatic way of putting it. It was not inferior to tissue genotyping over here. And I think this slide kind of sums up, this is how far we've progressed with our biomarker testing in breast cancer, irrespective of subtypes. When a patient progresses, we do have treatment options. And then we have those little off the label, which may not really be in our guidelines, but we do have options present. And on that note, thank you very much for your patient listening. Thank you.
So thank you, Dr. Aparna, for the wonderful talk. You have nicely illustrated the importance of genetics and subtypes of breast cancer and the genes involved. And by targeting these genes, how we can achieve maximum benefit by treating the patients. So, ma'am, I have one question. So, this is a routine difficulty we face in managing patients. So, we all know that tissue is the issue. So, most of the times in case of lung cancer, we won't be able to get the tissue. Mm-hmm. So do you think the ctDNA or NGS has the role in diagnosing the presence of malignancy and subtyping, whether it's squamous or adeno? So what is your comment on that?
Unfortunately, for pathological subtyping, I don't think liquid biopsy is there yet. There are some really good studies and work happening in the realm of circulating tumor cells, where they use a combination of staining, IHC staining using flow cytometry, but that's just work in progress. I do know Dr. Massimo, I forget his last name, who's in University of Chicago. They have been able to use CTC for calling out, if it's HER2 positive, ER/PR status in breast cancer. We still cannot call out and say if something is an adenocarcinoma, squamous. I don't think we're there yet. I think we still need tissue for helping, call out the genotyping. The calling out the pathological classification. I don't think a liquid biopsy is there yet for clinical practice.
We are hoping in future we can get this facility where we can diagnose
exactly, absolutely. Absolutely. But there's some great work happening in that field for sure.
Yes. Any more questions from the audience or panelists? So we can take. Otherwise, we'll move on to the next talk. So thank you, Dr. Aparna. So Pooja, can you please share the slides?
Sure, sir. Technical team, I have a request to you. Please stop the live streaming for this session, and we will continue after this session. Hello, support team.
Yes, ma'am. Just give a second.
Yeah, please. Hello. technical team?
Yes, just give us a second, ma'am. We are connecting with you.
Yeah. Just make sure that we are pausing the live streaming, and then we will continue after this session.
Okay.
Sir,
Okay.
yeah, we can go ahead, sir. Thank you.
Okay. So thank you. So I'm Dr. Trivikram, medical oncologist from American Oncology Institute, Hisar. So I'm going to discuss about role of immunotherapy in triple-negative breast cancer. So the burning question nowadays is, do we need to select any better patients or better drugs? So regarding answer, let's wait, and after the discussion, we'll come to know. Next slide, please. So basically, we all know triple-negative breast cancer is an aggressive histological subtype, and it accounts for almost 10 to 20% of the invasive breast cancer. It is usually associated with younger age, higher disease stage, and increased risk of relapse. The metastatic breast cancer portends a poor prognosis, and the median overall survival is approximately 17.5 months with the first-line chemotherapy. Next slide. So this is the diagram beautifully depicting the targets, the novel targets in triple-negative breast cancer and the drugs. So we can see here in case of PD-L1 and PD-1 pathway, we have the immunotherapy agents like atezolizumab, pembrolizumab, and durvalumab, even approved in the first line in case of metastatic breast cancer, also in the adjuvant therapy. So we have in case of PIK3 AKT-mTOR pathway, we have the AKT inhibitor, that is iptasertib and capivasertib. And also we have the androgen receptor inhibitors like bicalutamide and enzalutamide. And we have, in case of BRCA, we have PARP inhibitors like olaparib, talazoparib, and veliparib. And also we have the newer antibody drug conjugates like sacituzumab govitecan and letirotuzumab vedotin, targeting TROP2 and LIV3CA, KRAS, BRAF, EGFR, as well as in PTEN. So all these targets are being studied and drugs are being developed. So next slide, please. So the heterogeneity of the tumor immune microenvironment is consists of extracellular matrix and the stromal cell types, including immune cells, tumor-associated macrophages, TAMs, cancer-associated fibroblasts, and cancer-associated adipocytes and endothelial cells. So alterations in the microenvironment significantly influence tumorigenesis, disease progression, and response to the treatment. Presence of TILs, that is tumor-infiltrating lymphocytes in TNBC, are associated with greater response to both neoadjuvant and adjuvant chemotherapy. Next slide, please. So the prognostic implications of the molecular subtypes and the different relapse-free survival rates are depending, like the basal-like 1 tumors were higher grade but lower stage, but increased relapse-free survival and overall survival. The same were also almost likely to achieve PAT-CR with standard neoadjuvant chemotherapy. In case of luminal androgen receptor tumors, they have a high regional spread and regional lymph node involvement, and they preferentially metastasize to the bone, consistent with the disease course of ER-positive tumors, while the mesenchymal tumors had high propensity to metastasize to the lung. In case of basal-like immune suppressed type, they have the worst disease-free survival. Also, the basal-like immune activated variety subtype has the best disease-free survival. Next slide, please. So the future actionable targets in selected TNBC include the PARP inhibitors like the olaparib and all. In case of high copy number gains for PARP, PPAR1 gene, so-called the BRCA, and the MEK1 and 2 inhibitors in case of high copy number gains in KRAS, NRAS, and BRAF, and the PIK3 AKT pathway inhibitors in those with high frequency of PIK3 copy number gains. And again, the same PIK3 AKT inhibitors in case of overexpression of PIK3CA, AKT2, and AKT3 gene pathways. Next slide, please. So even in the case of M subtype, missing M subtype, the cell lines representative of this were responsive to tyrosine kinase inhibitors like dasatinib and also PIK3 mTOR pathway inhibitors. Next slide, please. So triple negative breast cancer, the breast tumors with an identity crisis. Next slide. So these are all the trials, list of trials where in the neoadjuvant setting, including the involving the immuno-oncology drugs like the immune checkpoint inhibitors. We can see in case of phase 3 trials, we have Keynote 522, IM Passion 31, and NeoTrip-A PDL1. So all these drugs like pembrolizumab and atezolizumab were tried along with chemotherapy in neoadjuvant setting. In case of phase 2 trials, we have JEPAR Nuvo, I-SPY2 and NCI trials, and few ongoing trials also. However, we have in case of neoadjuvant setting, we have pembrolizumab approved in case of as a neoadjuvant therapy in someone having high risk triple negative breast cancer. So next slide. So a lot of work is going on in this area of triple negative breast cancer. So basically the addition of immune checkpoint inhibitors to neoadjuvant chemotherapy improves the pathological complete response rate regardless of the PD-L1 status. 2 trials have demonstrated event-free and disease-free survival benefits with immune checkpoint inhibitors regardless of whether pathological complete response is achieved or not. Or the insufficient data to recommend ICIs other than pembrolizumab. So currently only pembrolizumab is only approved in the standard guidelines. So we'll see the data regarding this trial in the coming slides. So next slide. So this is the proposed treatment algorithm for early stage breast cancer in 2022. So along with neoadjuvant chemotherapy plus pembrolizumab in high risk early TNBC. So after the assessment, we subject the patient to the surgery. In those someone having PATCR, standard of care is adjuvant pembrolizumab should be continued. Otherwise, we can enroll them in planned trials of adjuvant pembrolizumab versus no adjuvant pembrolizumab. And in those with someone not achieving PATCR, in case of any suspected or confirmed germline BRCA mutation. So if there is BRCA mutation, we can consider adjuvant pembrolizumab along with concurrent or sequential olaparib. In case of no BRCA mutation, and we can consider concurrent capecitabine along with the pembrolizumab. Also consider concurrent radiation along with pembrolizumab. So these are the current guidelines we are following. So next slide, please. So this is the image depicting the standard NCCN guidelines version 4, the latest version in 2022. So the preoperative or neoadjuvant therapy regimens in case of HER2-negative, there's triple negative high-risk breast cancer. Preoperative pembrolizumab plus paclitaxel followed by preoperative pembrolizumab plus doxorubicin cyclophosphamide followed by adjuvant pembrolizumab is the current guideline which is approved in July 2021 by FDA. So we should always check for the high-risk features, and we should always counsel the patient for adding pembrolizumab whenever possible. So next slide, please. So this is the trial I'm talking about. This is a Keynote 355. Basically, it's a randomized, double-blind, multi-center phase 3 trial where the adult patients with previously untreated, locally recurrent, inoperable, or metastatic triple-negative breast cancer, and who have completed curative intent therapy more than 6 months before the first recurrence, having echo PS of 0 or 1, and total number of cases were 847, were randomized to pembrolizumab 200 milligram every 3 weekly plus chemotherapy versus placebo plus chemotherapy. So the primary endpoints being progression-free survival, overall survival. Also the secondary endpoints being overall response rate, duration of response, disease control rate, and the safety. So median follow-up is 44 months. So until progression or toxicity or completion of 35 cycles, the data was assessed. Next slide, please. So this is the original article, study of Keynote 355 done by Cortis and et al. Next slide. So we can see that when we compare in case of CPS score more than 10 or less than 10, we can see the overall survival graph in case of CPS score more than 10. We can see the this beautiful survival benefit the graph is beautifully separating. We can see the survival of 23 months versus 16 months. And the p-value also, the hazard ratio is good, 0.71. And in case of CPS score less than 10, there is not much benefit, that is 14 months versus 15 months. However, in case of further analyzing, comparing CPS score more than 20, less than 20. In case of more than 20, the benefit is also good again. We have 24 months of survival compared to 15 months. And in case of CPS score less than 20, it's almost similar without much difference. So we can say that the tumors having the high CPS score, at least more than 10, have good benefit by adding pembrolizumab to the chemotherapy arm. So next slide, please. So again, to conclude that among patients with advanced triple-negative breast cancer, whose tumors express PD-L1 of CPS score more than 10, addition of pembrolizumab to chemotherapy resulted in significant longer overall survival than chemotherapy alone. So next slide. So in case of stage 4, we can see the latest guidelines proposing that in case of triple-negative breast cancer, we should always check for PD-L1 status with IHC and someone having threshold of more than CPS score more than 10. Pembrolizumab plus chemo arm could be albumin-bound paclitaxel or plain paclitaxel gemcitabine carboplatin is the category 1 recommendation in first-line therapy. Next slide, please. Also, coming to recent advances, we have FDA approval in 2020 in case of sacituzumab govitecan for the lateral lines beyond first line. So we'll see how we are going to manage in second and third line. So immune checkpoint inhibitors are not a panacea for triple-negative breast cancer. That is not currently. This is not the one option to go where we treat everything. So a lot of genomic testing and markers need to be tested. So the genomic profiling and other sequencing technologies have led to better understanding of the heterogeneous biology of TNBC and allowed for identification of molecular subtypes of TNBC. A variety of genetic alterations found in TP53, BRCA, KRAS, NRAS, and PIK3 genes, amongst many others, and disruption in their associated cellular pathways provide opportunities for novel targeted treatments. And molecular studies have also uncovered the heterogeneity of the tumor microenvironment within TNBC subtypes, including vast differences in immune infiltration, localization, composition, and expression of targetable immune pathways. The success of these checkpoint inhibitors in clinical trials have led to the approval of atezolizumab in combination with nab-paclitaxel in metastatic setting, and also the approval of pembrolizumab in neoadjuvant setting in 2021. The first TROP2 antibody drug conjugate, that is sacituzumab govitecan, also approved in early 2020 for the refractory metastatic TNBC. These new approvals signify a long-awaited change in the treatment landscape of TNBC, but nevertheless, this treatment remains restricted to a small subset of these tumors. And novel treatment strategies for TNBC, such as combination treatments with both molecular targets and immune checkpoint inhibitors, as well as in combination with vaccines to enhance the T-cell priming and activation, are underway. Next slide, please. So we know the first line treatment is usually the immune checkpoint inhibitor plus chemo, which is depending on the PD-L1 expression, not BRCA status. Even in the first line setting, we should look into whether the patient is eligible for a clinical trial. In case of PD-L1 positive disease, we should choose chemotherapy plus immune checkpoint inhibitor regardless of the BRCA. And in case of PD-L1 negative disease, we should select chemotherapy, or in case of BRCA mutation is identified, a PARP inhibitor can also be considered in case of first line. Next slide, please. So in case of lateral line treatment, it is influenced with the BRCA status, relapse timing, and the toxicity of the drug and the other comorbidities. Next slide. So in case of those with mutated BRCA testing, so in the patient carries a BRCA mutation and has not previously received a PARP inhibitor, we should consider a PARP inhibitor for the second line treatment, and sacituzumab govitecan in the third line. However, next slide. However, in case there is the BRCA mutation is not positive, in case of wild type BRCA, so we should decide between second line treatment, that is chemotherapy versus sacituzumab. If the patient has progressed within 12 months of neoadjuvant therapy, I would like to select sacituzumab and reserve chemotherapy for the third line treatment. When the patient did not have any early relapse, then I would sequence chemotherapy before sacituzumab. And trastuzumab deruxtecan offers another unique targeted therapy option, but additional trials are needed to understand the appropriate use in metastatic triple negative, because it primarily targets the HER2 disease. So interesting to see whether how much benefit it provides in case of triple negative disease. Next slide, please. So to conclude, immune checkpoint inhibitors represent a much needed addition to the limited armamentarium against TNC, and the positive results to the addition of PD-L1 antibodies to chemo across several phase 3 randomized trials in both first line and neoadjuvant settings are encouraging. Given the historically dismal outcomes of the disease, these findings necessitate the adoption of immune checkpoint inhibitors as standard therapy for patients with stage 2 and 3 disease, triple negative breast cancer, and those with PD-L1 positive advanced triple negative breast cancer. Novel strategies for the PD-L1 negative advanced triple negative breast cancer are needed, and biomarkers to select the patients for neoadjuvant immune checkpoint inhibitor therapy require refinement to facilitate chemotherapy de-escalation. And future strategies include synergistic combinations with other immunomodulatory molecules, including targeted therapy for select populations, and a combination of PARP inhibitor with immune checkpoint inhibitor is of major interest given the incidence of BRCA, PL, PAL-B2, and other homologous recombination repair gene alterations in TNBC. Additional evaluation in randomized phase 2 and 3 trials is warranted. So several ongoing trials like IM-PASSION and BELLA are evaluating immunotherapy in patients with early relapse after curative intent therapy. So thank you. Thank you for the patient listening. So again, the answer to the question is whether we should select better patients or better drugs. So always the better drugs are combination for sure. So thank you. And I would like to conclude here. So are there any questions? So otherwise, we'll move on to the next talk. I think Dr. Manish Singhal has joined. So hello, sir. Good evening. So you're on mute. So I welcome Dr. Manish Singhal, Senior Consultant, Department of Medical Oncology, Indraprastha Apollo Hospital, New Delhi. Over to you, sir.
Right, thank you very much. And my slide sets are, I think, already shared with the organizers.
I think you're still in the hospital, I think.
Yeah, I'm still in the hospital. My life is like that. Perhaps you can see the patient sitting behind.
Yes, there's a reason. Thank you, sir. Thank you for taking your time out.
Yeah, thank you. Gariba from Horizon, can you just share the slide set? Yeah, so we'll be discussing on the flexible future and transforming the paradigm of HER2-positive breast cancer treatment. We have all known that HER2-positive breast cancer has seen quite unprecedented success, and in the recent times, it is the various destiny, and I think that has changed the destiny of HER2-positive advanced breast cancer, and is likely to make a lot of advancement even in early breast cancer as far as HER2-positive breast cancers are concerned. Next slide. Next slide. So we have seen that not only the advancement in the metastatic setting has very easily and very quickly percolated into the neoadjuvant and the adjuvant setting, and we have data sets which has shown that pertuzumab and trastuzumab combination not only increases overall survival but also increases pathological CR rates in the neoadjuvant setting and survival in the adjuvant setting in high-risk patients who are node positive. Next slide. So this has become, by and large, a very standard of care, and so much so that the guidelines have evolved to an extent that any tumor which is more than 2 centimeters or is node positive should receive neoadjuvant chemotherapy with a combination of pertuzumab and trastuzumab. So our usage of this combination has ever increased, and we have seen the better results. And there have been patients who have been going on for years together with this combination of pertuzumab and trastuzumab, even in the metastatic setting. Next slide. Giving pertuzumab, trastuzumab, of course, involves a lot of long infusions. It's challenging resource utilization, maintaining indwelling catheters for a long time with their own problems of thrombosis, discomfort. Even if they don't have an indwelling catheter, venous access can become an issue in breast cancer patient, and we all understand this. Next slide. So subcutaneous formulation of pertuzumab, trastuzumab is definitely, which is a welcome move. If you ask patients, they're quite elated about using a percutaneous formulation. But to give a very large volume, you need to have a recombinant human hyaluronidase, which can allow you to give larger units. How does this work? Next slide. So hyaluronidase actually disrupts the hyaluron in the subcutaneous plane, which can allow you to give a lot of volume, that is up to 15 ml, 20 ml volume also. Next slide. It does not disrupt the collagen. It does not disrupt any other structure, but or the elastin, but only the hyaluron, which can allow greater dispersion of the subcutaneously delivered drug, and thereby a larger volume can be given. The required dosage can be easily given in the subcutaneous plane. Next slide. And this degraded hyaluron can quickly be reformed so that the next injection can be given easily. Next slide. So this is how a bolus, if a bolus is given, and otherwise if a hyaluron injection is given, then there's no wheel formation. It just disperses into the subcutaneous plane into a larger area, and an easily larger volume can be given. Next slide. Next slide. So this is about the pharmacokinetics and efficacy and safety. Next slide. This proved that the fixed dose formulation that is required is 1200 milligram of pertuzumab and 600 milligram of trastuzumab given subcutaneously in a fixed dose formula in a loading dose, and 600 plus 600 of each in the maintenance dose. Next slide. So these are the various phase 1b dose finding studies. So this particular dose combination showed that the C trough level is reached with this formulation in almost all patients. Next slide. Next slide. So as I always say, that the proof of the pudding is in eating, and the Federica study is a study which looked at the various endpoints of using this formulation and comparing it with an IV formulation and in a neoadjuvant setting, and then the surgery is done. One of the key endpoints or secondary endpoints was pathological CR, which we clinicians are most bothered about. But the primary endpoint was non-inferiority, was that at cycle 7, the C trough level was equivalent between the two arms. Next slide. What do we mean by C trough levels? Next slide. So this is the C trough level. This is the just before the next dose, how much is the amount of the drug which is persisting in the system is the C trough level. So at the end of cycle 7, they looked at the C trough level and they found that the C trough levels was quite equivalent, which we'll just see. Next slide. So this is the C trough level. If you look at the fixed dose combination of pertuzumab, trastuzumab, it was 88.7 versus 72.4. So this is better off. This is for pertuzumab, and even for trastuzumab, it was 43.2%, 43.2 versus 57.5. So it was actually better off. So more drug was available at on cycle 7 at the just before the next cycle. So C trough is quite well maintained, and that helps us reconcile that yes, the fixed dose formulation achieves good amount of drug. Next slide. This is the pathological CR, and as you can see that the pathological CR is quite well matched between the two arms, 59.5% versus 59.7%. Based on the body mass index also, it is almost quite well balanced between the IV formulation versus the subcutaneous formulation. There are certain outliers, but that's largely because of the low number of patients that you see. There's a vast variance over here, but that's largely because the 95% confidence intervals are still overlapping. Next slide. These are the toxicities. The toxicities are quite well matched, and there is no differences in the toxicities. Next slide. Discontinuation rates are same. Next slide. Next slide again. Diarrhea. Everything is quite well matched. So I need not dwell on this. This is quite well matched between the two between the IV and the subcutaneous formulation. Next slide. Next slide. Something which I find quite interesting is that secondary cardiac events seem to be lesser. That is, initial left ventricular ejection fraction, confirmed secondary cardiac events seem to be lesser with the fixed dose formulation as compared to the IV formulation. This may be because the Cmax is lesser with fixed dose formulation, because the drug gets gradually absorbed, not like IV formulation. So it appears that it may be lesser, but that may or may not be the explanation because as per statistics, this is not statistically significant. Next slide. So fixed dose formulation was non-inferior as far as C trough level is concerned on cycle 7, that is pre-dose cycle 8. Pathological CR rates are quite well matched. Safety profile is very comparable between the IV and the subcutaneous formulation. Next slide. Now coming to patient question, whether patient prefer it or not. Next slide. That is a Fonseca study, and then that showed that the subcutaneous formulation, next slide. So patients were switched between subcutaneous and IV, and when you switch them between subcutaneous and IV, most patients preferred, 88%, 83%, they preferred the subcutaneous over the IV formulation. Next slide. And so more patients were satisfied with this. Healthcare professionals, even the healthcare professionals were more satisfied with the subcutaneous formulation than the IV formulation. Next slide. So this shows that how much time is taken up in the treatment room, in the drug preparation room between a subcutaneous formulation versus IV formulation. The time difference is huge. Subcutaneous formulation is much faster. Next slide. So you definitely save upon time. Adverse events, again, the adverse events were very well matched between the two, subcutaneous and IV formulations. So no difference over there, even in this Fonseca study. Next slide. So both healthcare professionals and patient satisfaction was better off, which was the primary endpoint of the study, as far as subcutaneous formulation is concerned. Next slide. What are the practical considerations? Next slide. Of course, these are very simple and very understandable, that you need to have privacy for the patient. Do not split the doses into 2 syringes. You have to give the entire dose in 1 syringe. And the syringe is provided by the company. The needles, the loading needles, the subcutaneous delivery needles, everything is provided in the kit. So you don't have to bother about all those things. Of course, you have to take the consent. The skin should be clean, hygienic. All these things are very, very self-explanatory. Next slide. So the loading dose is given over 8 minutes. That is 2 minutes, 2 ml per minute delivery, because it is 15 ml, so 8 minutes. And the maintenance dose is given over 5 minutes, because that's 10 ml. So 2 ml per minute is the infusion rate. And you have to catch hold of the lateral part of the thigh. So you can choose one thigh at one time, one thigh at the other time, and you can change the places a bit. But I think that the hyaluronate easily gets reformed, so you can give it in the same place again. But the recommendation is to keep changing sides. And it is given in the thigh, not in the arm or anywhere else, or in the abdomen. The thigh region is the region which is to be used, the lateral part of the thigh. Next slide. Ideally, a patient should be monitored for about 30 minutes after the injection, but so far we have not found any major allergic reactions. Next slide. So next slide. So very quickly, shorter administration time, less invasive administration, no need of any indwelling catheters or IV cannulas. No dosing errors because it is fixed dose, so you don't have to calculate anything. Reduced time for drug preparation and administration. No new safety signals. Next slide. So summarizing, both preparations are efficacious. They achieve same pathological CRs, C trough levels, so no difference over there. But the Phesgo seems to be preferred. Next slide. Seems to be preferred by both patients and healthcare professionals. And as such, the efficacy data shows that everything seems to be quite same, and there is no new safety signals. And as such, it is irrespective of the body mass index that the pathological CRs are achieved in the same manner with the subcutaneous formulation. So there has to be a reason for not giving an option of a subcutaneous formulation to the patient. With that, I thank you for your kind attention, and back to the organizers.
Thank you, sir. Thank you for the wonderful talk. So myself, I myself have some few questions for you.
Yeah, please.
So like how did your practice change? Have you moved from IV to subcutaneous in toto, or you're still prescribing IV formulations?
It is changing quite rapidly. I think now we are more comfortable with giving the subcutaneous formulation to patients, and I don't really see any reason that why we should not do it. And it is more cost effective because the loading dose is given free once you purchase the second dose. So even in a neoadjuvant setting where patient used to take 6 cycles of TCHP, now the cost used to come for only pertuzumab to be about 10 lakh rupees, and the additional cost of Herceptin, which is Herclone or whatever brand you may use. Now the cost is 7.5 lakh rupees. So from 12 lakh, it has come down to 7.5 lakh rupees.
Yes.
Practically, if not 7. Maybe 8 means they keep changing the. So ballpark figure is about 7.5.
Yes.
Only pertuzumab used to be 10 lakh. Additional cost of Herceptin used to be maybe, even if you choose the cheapest one, another 2 lakh for 6 cycles. So now that used to come out to be 12 lakh. Now that has come down to 7.5 lakh rupees. I'm not talking of drug cost because it's a fixed dose formulation. You don't have to buy trastuzumab separately. So definitely the practice has changed mainly because of quite rapidly because of the cost consideration. You're saving a lot of cost.
Yes.
Then
So
this is a OPD. I gave the first shot to a patient in the OPD today.
Okay.
First loading dose.
Great.
Bed cost bach gayi.
Yes.
In a corporate hospital, the patient can get this injection from outside also. I hope the corporates are not listening. So the subcutaneous injection you can in the OPD you can give. Why the patient has to buy the injection from the hospital? Because corporate hospitals, they necessitate that everything has to be bought from the hospital.
Yes.
It's a simple injection. You can administer in the OPD. So you save on the bed cost also. So lot of cost saving is there. So that makes it very compelling to use it.
Yes, exactly. I totally agree, sir. And sir, what about using the fixed dose combination for someone having weight of around 35-40 kilos? Are you comfortable using the fixed dose combination? Like
I'm okay. ऐसे patients बहुत कम होंगे that those who are very lean and very thin. I'm okay. They may have more drug in their system. At least there's no toxicity concern. Although the pathological CR was higher in the in those patients who received the IV formulation, but there were like 3 patients and 7 patients. And look at the 95% confidence intervals. I'm okay to use it. As far as it is cost saving, I don't mind.
so even for obese patients, the cost drastically
The
reduced.
dose of pertuzumab is anyhow fixed.
Yes, yes. Only trastuzumab.
It's only about the trastuzumab. Trastuzumab तो आपको free मिल रही है.
Yes, yes.
Within the fixed dose formulation. आपको तो cost extra नहीं पड़ रही. So then why not?
Yes, exactly. So are you routinely using sir pertuzumab in neoadjuvant and adjuvant settings?
Yeah, those patients who qualify for neoadjuvant, I would use it.
Okay. Okay.
I would definitely counsel them. I would like to use it, but then those who qualify for neoadjuvant, that's their only chance. Means once they hit a pathological CR, then we know that that is going to change their outcome quite drastically.
Even in adjuvant setting?
Adjuvant setting only in node positive patients or those who are very young, can afford large tumor, even if node negative. I would certainly use it. Especially ER negative, HR negative, HER2 positive patients, I would use it. I would definitely counsel them better to take it. If the surgeon has been very aggressive with surgery and they have not referred the patient with such a large tumor. Ideally, a adjuvant patient, either it should be a unidentified lymph node which came out to be positive, which was expected to be negative. Then, of course, then they are node positive. So if they're node positive, then they got to take the injection. Especially if they have heavy nodal burden, more than 4 or more than 4 nodes.
So in our setting, like I'm practicing NISAR, it's a common thing to operate the even stage 3 disease also node positive because the patient tends to.
Then you got to do more CMEs with them. You need to teach them that this is not correct. This is exactly what we need to do.
So the surgeons are willing to.
It's not that there's lack of will, there's lack of education, awareness. They don't have the awareness that, what wrong can happen or what better can happen if you do neoadjuvant chemo. You don't lose out on anybody. Because the results of HER2 targeted therapy is so very gratifying.
Yes.
Right? The surgeon will have a glorious time operating on them.
Exactly. So the surgeons are willing to refer, but thing is that the patient has a fixed mentality. So there is a tumor, they just want to remove it first. Surgery, surgery, surgery. Some patients
But
come
if you
with fixed
spend that
mindset.
extra time with them, counsel them that this is what
Yes.
America is doing. You want to do something else.
Exactly.
You are sitting in 2022. You've got to treat like 2022. If you still want a treatment which is of 2000, then fair enough. Tell them
I
that.
totally agree with you. Yes. But even sometimes we find those cases already operated from periphery. General surgeons operate and send it to you for adjuvant thing.
So then you need to hold more and more CMAs.
Yes,
Show them your magic of your drugs, the magic of your drugs. हमने तो vanish कर दिया ना. आपके तो surgery के अंदर pathological CR tumor ही नहीं मिला.
Yes, exactly. Thank you, sir. Thank you so much.
Pleasure.
So I think Dr. Ulas hasn't joined. I think Pooja, what do you say?
Sir, Dr. Ullas sir will be joining in few minutes. If it is okay, so can we go ahead with Dr. Sushant Mittal sir session?
Yes, sure. So
Dr. Sushant sir, are you there?
Yes, sir has joined. I think he's on mute. Sir, please unmute yourself, Dr. Sushant. Dr. Sushant? Yes.
Sir, with your permission, can we go ahead with your session next?
Dr. Sushant? Hello, Dr. Sushant. Good evening.
Hello. Hi, Dr. Srivikram. Good evening. Can you hear me?
Yes, you're audible, sir.
Okay.
So it's a sponsored session by Intas. So I welcome Dr. Sushant Mittal, Senior Consultant Medical Oncology, Action Cancer Hospital, Delhi. So over to you, sir.
Thank you. Please allow me to share my screen. Yes. Okay, fine. Thank you. So good evening, everyone. So session given to me is to talk about the role of capecitabine when combined with cyclophosphamide, and its usage and its indications, and why is it helpful. So we all know that capecitabine is a drug which is used commonly in oncology, especially in breast cancer. We have been using it, and it's a drug in probably in third line when we have run out of atreomycin and paclitaxels, and then for patients we have options of gemcitabine or capecitabine. So when we combine with any of the drugs such as cyclophosphamide or docetaxel or paclitaxel in any format, so why is it preferred partner? Because of its high single agent activity, unique safety profile, there is no alopecia, the myelosuppression is manageable. The drugs such as Pacli, Dosi, and Cyclo with thymidine phosphorylation activation is helpful, and data on the efficacy with a combined use of drugs including capecitabine is very limited. So the rationale of combination of capecitabine with cyclophosphamide is that capecitabine, a prodrug, when enters into liver, is converted into 5-deoxyfluorouridine, and into the tumor with the help of thymidine phosphorylase converted to 5-FU, which is the active agent. And cyclophosphamide, besides its own anti-cancer effect, synergizes with the upregulation of thymidine phosphorylase, and hence is able to give capecitabine an edge to work better and harder when combined with cyclophosphamide. So when we combine the two drugs, there are multiple mechanisms of action on the breast cancer. It has a direct effect on the cancer cells. It has an anti-angiogenic effect, immune-mediated effects, and endocrine effects, which leads to anti-tumor clinical benefits. So the existing data is very limited. There is no randomized phase 3 trial for this combination. There is no PK data. There is no confirmation of the synergism. And the doses used were not metronomic or used as a separate drug administered, and was not a fixed drug combination. So there was no systematic drug development due to formulation challenge. And hence this trial, a phase 3 study, a prospective trial, adaptive, randomized, open label, multi-center clinical trial to assess the efficacy and safety of fixed dose combination of capecitabine and cyclophosphamide in patients with metastatic breast cancer with failure of anthracycline and taxane chemotherapy, which is an indication in real world. We commonly come across such kind of patients. So the investigational drug had two combinations of fixed dose combination of capecitabine with cyclophosphamide, 700 plus 30 mg respectively, and 400 plus 20 mg respectively. And the groups were dose level 1, in which 1400 plus 60, group level 2 was 1800 plus 80, and group level 3 was 2200 plus 100. So these three group levels were tried, and the DCGI permission was taken on 29th August 2014. The study had two parts. The part 1, the patient were randomized to receive FDC of capecitabine and cyclophosphamide in 3 different doses at level 1, 2, and 3, as I told you previously. And the key inclusion criteria were, which commonly are there, it is females more than 18 and less than 65, proven breast cancer, and had a failure of anthracyclines and taxane regimens with measurable disease. Exclusion were hormone positive patients, or who had taken more than 1 prior of chemotherapy, patient with CNS mets, and pre-existing motor or sensory neurotoxicity more than 2 were not included. Total 235 patients were screened, and out of which 69 was failure. D1 was not included in second part of the study. The D2 and D3 patients were assessed majorly. And if we see the dose level 2 and 3, the median age group was about 49 to 47 years. BSA was 1.5, which is usually the Indian BSA of the patients. And majority of the patient had ECOG performance 1. If we see with the intention of treatment, the responses were, the majority of the responses were partial response, but if we combine the total responses of CR plus PR plus stable disease, we can see up to 87% of the patient received a response either in dose 2 and 84% in dose 3 category of the patients. The side effect profile, majority had mild side effects, and just about 8 to 10 patients numerically, not percentage wise, numerically had severe toxicity. Major toxicities were grade 1, and anemia and leukopenia and neutropenia were there, which was manageable. Others, such as hand and foot syndrome, was present in about 16 to 18% of the population, which I think most of us can handle easily. Asthenia was more in grade dose level 3. Similarly, vomiting and pyrexia was little higher in level 3 of the population. When compared with the published historical data, most of them was retrospective. We see that the present study has shown a total response of about 87 to 84 compared to other trials such as Japanese trial or Harvey trial, Scott et al., which is showing that responses were about 57 till about 68%. So this trial had shown the maximum responses to the tune of 87%. The challenges of fixed drug combination was incompatibility between the two molecules, chances of impurity generations, particle size, and differential release. And this was very well circumvented, and the company was awarded patency for particle size and patent in the process for tablet in tablet format. The outside layer is the capecitabine and the inner one is cyclophosphamide. That's why this tablet, it cannot be crushed or dissolved in the water and given through Ryle's tube. It has to be swallowed. So it's a core tablet in tablet formulation. The sizes are, it's comparable to the other commonly used tablet formations and is easily palatable and can be swallowed. So DCJ approval was given on 28 April 2020. And these are few of the trials in which fixed dose combination of capecitabine and cyclophosphamide in metastatic breast cancer. This is the enclosed trial by my mentor, Dr. Sudeep Gupta. And the conclusion was that cyclophosphamide demonstrates synergistic anti-tumor activity in combination with capecitabine. As I told you, the efficacy established in metastatic breast cancer through a robust phase 2 and 3 clinical trial. Based on the CT and detailed review of comparative literature, it has been prepared. Only FDC that used a proven flat dosing concept and convenience of taking tablets instead of many tablets. Either instead of taking 2 tablets, 1 tablet is enough. That is cyclophosphamide, capecitabine can be combined together, and so it's a convenience of taking the drug. Capecitabine in triple negative breast cancer, a meta-analysis is one of the most commonly used drug in neoadjuvant adjuvant setting, and 2 meta-analyses have shown, and even in our clinical practice we have seen that capecitabine gives a DFS and OS benefit in TNBC patients. A subgroup analysis was conducted to explore the potential benefits of combination of cyclophosphamide with capecitabine, and it showed that there were 12 randomized controlled trials. Total of about 4,800 patients were taken, and the forest graph shows that all these trials has a not much of a difference, but definitely it favors capecitabine. Diamond may not be very well away from the unity, but yes, definitely it is away in majority of the trials. So significant improvement with cyclophosphamide is also seen, and that's why this combination has been shown to be beneficial in the trial setting. So the adjuvant capecitabine could bring in significant benefits on DFS and OS to the unselected TNBC population. The combination of capecitabine and cyclophosphamide could be used to improve the survival of such patients. And I like to present one of my own patients. She is a 47-year-old lady who presented with lump in right breast, and she was diagnosed as CA breast in 2019. She underwent MRM in June 2019, followed by 4 cycles AC and 12 cycles taxanes. In the next December follow-up, she had shown the signs of progression, for which she was given gemcitabine and carboplatin as third line, and she had shown a response. And after that, patients didn't want further intravenous chemotherapy, so she was shifted in oral capecitabine. In September 2021, she presented with imbalance while walking, and then PET scan was done, which showed she had a cerebellar lesions and the lung lesions, as can be seen on the PET scan. Patient was symptomatic, hence underwent a radiotherapy, and she was advised to continue the chemotherapy. However, patient was not willing for intravenous chemotherapy because she was from a MCD panel. She had already spent a lot of money, and the reimbursement was taking a lot of time. So she was tired of taking the treatment, and she didn't have the financial strength also to take the therapy. So I started ComCaps in 2021 as I had no other options. I knew I had already given capecitabine and she was progressing, but anyway, something is better than nothing. This drug was there. So I started with Comcapsy in this patient. And if we see in January 2022, her PET scan showed that there was a near complete resolution of the pleuropulmonary nodules and patient had performance status 1. Then I did a PET scan in around May, which showed she was in complete remission. And now she again underwent in September 2022. She again underwent a PET scan, and she was continuing Comcapsy, and she is still in CR, and she is doing well, and she's happy. And the patient is well maintained. In fact, she came today also for the same combination, and patient continues to do well. So I believe that this metronomic therapy definitely is a boon for patients, not only who can't afford financially, but also for patients on whom we have run out of options and can be given such therapy, which is proven, which is financially viable, and had shown responses also. So with this, thank you so much. Back to the organizers.
Thank you, Dr. Sushant. It's a great talk. Also, great case presentation, because great to know that, good to know that people responding very well to the metronomic therapy going into CR. So good to know. Sir, in your practice, like what is the subset of patients where you prescribe Comcapsy routinely? So is it in metastatic only, or like?
No, I use only in metastatic cancers. Even I have tried in few of the head and neck cancer, and I am surprised that one of my lymphoma patients I had to give, because she was from EWS category and she had run out of R-CHOP and R-GDP, and she was not fit. So she's also responding very well to Comcapsy. So I am using the drug widely as a metronomic therapy, especially for patients, as I told you, who are unable to afford or not fit for intravenous chemotherapy, and on whom I have run out of options. So I feel that this drug can definitely help for such is a helpful drug for such kind of category of patients.
Good, sir. And sir, in your practice, like what is the dose you're prescribing? So are your patients able to tolerate the thrice daily regimen, or like what's the dose you're comfortable with?
I'm using 700 tablet morning, 700 evening maximum. 700, 400, or 700 in the morning, 700 in the evening. That's all I'm using. Maximum dose. That's what I've been using, and I'm comfortable, and I'm getting responses in that.
Yes, sir. Thrice daily is a little more toxic, I think.
Yes.
For the patients. Yes. Thank you, Dr. Sushant.
Thank you, Dr. Reversion.
So I think Dr. Ullas sir has joined. So welcome, sir. Dr. Ullas, good evening, sir. Thank you for taking your time. So next session sponsored by Roche. So I welcome Dr. Ullas Batra, Senior Consultant Medical Oncology, Chief of Thoracic Medical Services, Rajiv Gandhi Cancer Institute, Delhi. Over to you, sir.
Thank you. Sorry, I was held up in the Karwa Chauth jam, the pre-Karwa Chauth jams. You know, I mean, so I will not make a MCP comment right now, because I'm very scared if my wife eats something in the day tomorrow, then my life will be shortened. So the joke will be reserved for OMCT and immunotherapy today. And I was listening to the earlier talk, and from a very cheap way of giving a metronomic chemotherapy and getting a CR. So now going on to slightly more expensive way of getting a complete response in non-small cell lung cancer. So this is a sponsored session by Roche, but unfortunately I am not using their slides, and I will be using my own slides and my own thinking about how best we can optimize the management strategy for patients with first-line metastatic non-small cell lung cancer. So my first reactions when I heard this topic about optimizing the first-line strategies in non-small cell lung cancer was to look at the definition of optimize. And the meaning of optimize is to make as perfect, effective, or functional. I think atezolizumab will actually fit the bill for effective, functional. Perfect we will think about in certain cases, yes, in certain cases not really perfect. But definitely effective and functional is something which is to be associated with atezolizumab in stage 4 non-small cell lung cancer first line. Also to make the best possible use of something, and that something also comes with the cost. So if India is a cost-constrained country, we were speaking about OMCT being given 20 minutes of talk and immunotherapy is also being given 20 minutes of talk. So to make the best possible use of something, atezolizumab I think will be very, very useful. My subsequent reactions on optimization was basically about the strategic plan. So what is the strategic plan and what ways can we best utilize atezolizumab in the treatment of first-line metastatic non-small cell lung cancer? So I will be talking about 3 trials. Very, very easy. IM power 110, add another 20, 130, add another 20, 150. So 3 trials, 110, 130, 150. 110 is single agent, 130 is triplet, and 150 is 4 agents. So again, easy to remember. Otherwise, I also don't remember what trial was it. IM power 110, and there is 010, which is there for the adjuvant setting. So let's go to the IM power 110. I'll keep it very, very short because today is Karwa Chauth, and everybody who doesn't go and take their wives to Mehndi ceremony, if somebody eats a food tomorrow, it will be an issue. Just joking. I think Karwa Chauth is some festival where both the wife and the husband should keep fast for each other for their good and happy lives. So I'm going on record, and I hope my wife is not listening to this. Okay. So the first one is IM power 110. In this trial, this is almost like a keynote 24 or 42, or if my BMS friends are listening, Checkmate 26 trial, where a single agent atezolizumab was compared between chemotherapy. So if you had a atezolizumab 1200 mg versus either squamous or non-squamous, in squamous you use in non-squamous you use carbo or cisplatin plus gemcitabine. In non-squamous, you use pemetrexed carboplatin, and then you give them maintenance. So immunotherapy versus chemotherapy was the trial design, and the analysis basically over here was they will first look for the assessment of this in the TC3 or IC3. TC3 IC3 by SP142 is what we typically associate with PDL1 more than 50%. TC23 or IC23, that is PDL1 1 to 50. 1 to 3 or 1 to 3 means anything more than 1. So that is where the hierarchy analysis was there. So this was the primary endpoint of the trial, which was very, very nice, and which we basically found out was that a single agent atezolizumab improved the median overall survival by around 7.1 months against chemotherapy. And the HR was a fantastic 0.59. For all the people who had listened to Opto yesterday, we also spoke about, well, median is not the right thing in immunotherapy, but in this trial, you are getting a median OS advantage as well as you are getting a delayed separation of the curves. So 20 versus 13 is a fantastic with an HR of 0.59. So this trial was definitely very, very positive trial. Was there a subgroup analysis which did not benefit? And this is something which is very close to my heart. In anybody who has never used a tobacco, I do not usually give a single agent immunotherapy. I would rather give a combination immunotherapy or chemotherapy at that time. So in a never used tobacco patient, a single agent immunotherapy was not found to be betterment, was not found to be better. And partly the reason I feel could be because they did not, they looked only for EGFR-ALK. They did not look for other biomarker-related lung cancer. So to me, if you have a EGFR mutant, if you have a mutant stage 4 lung cancer, PDL1 90%, please do a NGS before you give them a single agent immunotherapy. If you want to give them an immunotherapy plus chemotherapy, that's absolutely okay, but then also do NGS in that. With longer follow-up, there was a continued OS improvement, and this happened in spite of the 35% of patients crossing over. So again, I would like to remind you, how do you assess the HR? Assess HR is basically numerator by denominator. By denominator, people who had got chemotherapy, if they got immunotherapy in second line, their median OS was better. But even in the updated OS analysis, we basically found out that the patients who had taken immunotherapy to start with did again much better than patients who had not taken immunotherapy. So again, this trial basically goes to show that, immunotherapy, if anybody can afford immunotherapy, you should be giving them in the first line and not waiting for the second lines to come. Now, this was the TC3 and IC3. Now, what happened in TC2 by 3? And if you look over here again, the HR was 0.72. The p-value was 0.04, but again, this did not cross the pre-specified boundary. So my advice to all the residents, if they ever listen to this talk, is please look at the pre-specified boundaries also. And HR was significant, but this was not statistically significant. So if it's almost like the keynote 42 trial, which also said that immunotherapy works in PDL1 more than 1%, but again, this was not statistically significant. Since it did not basically cross the TC2 3 and IC2 3, they did not formally assess in OS and TC1 2 3. But again, numerically, there was an advantage of immunotherapy over chemotherapy. This is something which is very, very important as far as I am concerned. I'm sure somebody will ask me whether I do SP142 for my PDL1 testing. No, I don't. I don't do SP142. We do a 22C3 or we do a SP263. So in this trial, what they did was there was a pre-specified PDL1 biomarker analysis. And what they basically found out was that if you had a TC3 or IC3 wild type, was almost comparable to the people who had a 22C3 positive, which was also comparable to SP263. The advantage of single agent immunotherapy was equal in all the three subgroups. So if you have a SP263 more than 50% or a PDL1 more than 50% by 22C3, you don't need to test it by SP142. This trial has proven conclusively that a single agent immunotherapy is good enough for these people of PDL1 more than 50%. There were no new side effects. We know that the grade 4 side effects were minimal, and whatever side effects were there, if you have nausea, vomiting, thrombocytopenia, more with the chemotherapy arm. You have increased ASG, pruritus, hypothyroidism, that is more with the immunotherapy arm. So nothing really changed. I think one of the major important adverse events which we don't tend to report in immunotherapy is the fatigue and weakness. The reports are fantastic, but the patient feels fatigue. So I think fatigue is also something which we should, report more often, which was again more with the immunotherapy arm. So this basically led to an approval, and atezolizumab is now approved in squamous cell and adenocarcinoma PDL1 more than 50% as a category 1 recommendation, and as is the category 1 recommendation for pembro or a pembro plus chemo or atezo. Other agents are not really approved as single agent. So whether it is pembro or it is immune or atezo, both are approved as a single agent in adeno and squamous PDL1 more than 50%. Even the ESMO guidelines say they are approved. How can there not be a cross trial comparison? Because in India, what you look for is mine is better, and I only will go and speak for Merck in the next session, and I'll tell this. So let's just have a cross trial comparison with a caveat that it's a cross trial comparison. So let's look at the cross trial comparison. IM power 110. Your median OS was 20.2 versus 13.1, and that's the problem with the Merck faces. In Keynote 24, which only included PDL1 more than 50%, your HR was 0.64, but the median OS was 30.2 versus 14.2. This is what I go and show to everyone. In Keynote 42, which was more of a atezolizumab kind of a trial, the overall survival was 20 versus 12.2. So if you leave out the Keynote 24, by and large, the results of IM power 110 and Keynote 42 are by and large similar. So, and the grade 3 A4 AEs and everything, and the 3-year OS rate, the median PFS, the objective rate are by and large similar between the two arms. So my conclusions about immunotherapy in stage 4 non-small cell lung cancer between atezolizumab and pembrolizumab are, we are not the same, but we are equals. So if you have a patient of PDL1 more than 50%, I would be absolutely okay in choosing a single agent atezolizumab versus a single agent other immunotherapy also. Then it is left to the discretion of the individual oncologist, whether they want to give a single agent immunotherapy with atezo or whether they want to give a single agent immunotherapy with any other drug. Any other drug, I mean only one company, which I'm not supposed to name over here. Don't keep on giving them single agent nivolumab or durvalumab, and then that's not the right one. So either a single agent pembrolizumab or a single agent atezolizumab in PDL1 more than 50%, if you decide to give them a single agent immunotherapy. So that's my conclusions about the Empower 110. At least in PDL1 50%. Definitely they are not the same in PDL1 less than 1 and 1 to 50. Now that brings me to the second trial. So 110, we are going to 150, which is basically about the atezolizumab in combination with bevacizumab and chemotherapy. I have said a long time before, my fond memories of ABCP include that there was a debate between Dr. Sahu and Kumar, and one of them said NSCLC 4 drugs in stage 4 non-small cell lung cancer, leukemia treat kar rahe ho kya? I mean, here you want to give single agent immunotherapy, and now you want to give 4 agent chemotherapy, immunotherapy. My subsequent reactions over here was that why do you want to give a 4 agent therapy in that? And I actually thought ki kuch to hoga. I mean, Roche is spending so much of money on 4 drugs, ABCP. अच्छा ही नहीं से बुरा तो होगा, and कुछ नहीं होगा तो पढ़ ही लेंगे. So let's read about why do they want to give 4 drug ABCP. So let's go down to the why of ABCP. Please remember there was a trial which was published in 2018, which basically compared pemetrexed cisplatin versus paclitaxel. So US, you wanted the North America wanted to give paclitaxel, and then this was compared against pemetrexed cisplatin. So the backbone of chemotherapy was pemetrexed cisplatin. You add up pembrolizumab, it becomes a Keynote 189 regimen. On paclitaxel, you add atezolizumab, it becomes an Empower regimen. So that is the concept of the 4 drug regimen. Nothing else. Roche is not mad to give a 4 drug regimen. That's the company because they wanted to add upon their own drug of paclitaxel. They believe in bevacizumab. Bevacizumab, half the word believes, half the word doesn't believe. I will not tell you which part of the word do I belong to right now, but ABCP is what I'll talk about. There is some more rationale, there's some 6 R's in that basically, that you recognize more immune cells, you recruit more cells, you reprogram them, you restore their function, and then you get more death, but that's a preclinical value. So what they basically say is atezo plus bev is 1 plus 1 is 11 over here. It is not 2 actually. So this design, again a complicated design, but I'll make it very simple for you. 3 arms. The control arm is the one which is the C arm, the paclitaxel, what we said. The A arm is basically when you give only immunotherapy, atezo plus pacli plus carbo, almost like a IM power 131 kind of a regimen. Arm B was ABCP. So arm B is something of interest that we will see. They compared arm B versus C. They compared arm A versus C. What they basically found out over here was, and this trial was very okay because they took EGFR and ALK rearranged people also. There's something which nobody else takes. So this was the updated PFS analysis. Again, you see the median is almost similar till over here, but after that there is a HR of 0.59, 8.3 versus 6.8. And more importantly, you have a 18 month survival of 27% versus 8% in the PFS. That's very, very important. That means the tail of the tail, which is very, very important. This was the OS advantage. The HR was 0.80. We just saw an HR of 0.59 in PDL1 more than 50%. You have a 5-month median OS advantage. And again, the tail seems to be flattening out over here. That was there. Again, does it work in all? Yes, it works in all. It works in PDL1 negative, PDL1 low, PDL1 high. It works in all the 3 subgroups. Obviously, the advantage is increasing as the PDL1 score increase. So if you are a paclitaxel fan and you want to work, if you want to give chemoimmunotherapy, ABCP is a very good regimen. Whether I am an ABCP fan in the first line in that is a question that I will answer in the subsequent question answer session. I am not actually, but there are certain subgroups in which ABCP has found to be very effective. What are those? If a patient basically has got liver metastasis, so if you have liver metastasis, the normal chemoimmuno doesn't really work. So here your liver metastasis wild type, the HR for ABCP versus only paclitaxel was 0.54, and something which is very, very important again for me is the EGFR ALK population. So if you have an EGFR ALK population and if you have given osimertinib or dacomatinib, and if you do not have a T790M, then this is the subgroup in which this patient acts very, very, very well. Now, is this only what Roche is saying? No. This is also a management of EGFR mutation after osimertinib. This was an article which was published, I think, in IACLC. And they are saying if you do not have a mechanism, then you can give giving ABCP in this subgroup actually. So the conclusion for me in the IM power 150 is there's a time and place for everything. And definitely atezo and bev has a very special place for me as far as progression after an EGFR mutant non-small cell lung is concerned, definitely I'll consider. In patients with liver mets, a very high volume of disease, I may consider, but definitely after EGFR mutant non-small cell lung cancer, I will want to consider. That brings me on to my last one, that is a non-squamous. I can see Dr. Rao looking at his watch. I think we're already late, so I'll finish it up faster. Now, this is a non-squamous non-small cell lung cancer. There are a lot of people, and the more keynote 189 I'm using, I am beginning to realize the renal dysfunction. For all of you, please look at the kidney dysfunction. Please don't look at only 1.3, 1.4. Calculate the GFR also, because that is, sometimes it comes to less than 44, 43, and pemetrexed is not supposed to be given in those. Now, this trial design is complicated, but I'll just tell you, this is basically a steroid sparing regimen. When was it decided? This trial was designed in 2017, 2018, when there was a lot of concerns regarding immunotherapy and steroids. So Roche thought they had a winner. We will give atezo plus carbo plus nab-pacli versus atezo, only pacli and carbo, followed by pemetrexed as best supportive care. Again, what this trial basically showed was that the addition of immunotherapy was better. The landmark 12-month analysis was better. Everything was by and large very, very good in this. And OS was also significantly observed with an HR of 0.79. So if you have a patient whose creatinine is 1.5 and you cannot give this, and if somebody's got an uncontrolled diabetes, there's a time and place for atezo, because otherwise what do you give? You can't give gem carb. So atezo nab-pacli carbon, atezo is approved in India for that indication also. Again, no OS benefit was observed over chemotherapy alone in EGFR ALK positive NSCLC. So if you have a patient of EGFR ALK rearranged non-small cell lung cancer, please do not give them only Keynote 189 regimen or IM Power 130 regimen. The only way immunotherapy works in post EGFR TKI in progression is if you give ABCP. That's the message which I want to make it very clear. A lot of times I get a call from all my friends, sir, PDL1 was 58% and patient has progressed on osimertinib. Shall we give pembro pem carb or atezo pem carb or atezo pacli carbo? It does not work. The only thing which works over there is ABCP, and that's it. Again, the toxicity profile was by and large normal. So again, the key conclusion of IM Power 130 is basically about use of a steroid sparing regimen. People with uncontrolled diabetes, people in which you are suspecting a diabetic nephropathy, you can use this regimen. So to conclude, I think I would like to, this is atezolizumab who is saying, hello, I am here too. I may be a late entrant. I may have got lesser approvals, but in the stage of first line stage for non-small cell lung cancers, atezo is definitely a part of my armamentarium. It doesn't take the entire cake, but there is a definite place for this in the first line NSCLC. With this, thank you, and I hand it back to the organizers.
So, as usual, wonderful talk, sir. So, great dissection of trial data. So, every time I listen to you, always we learn something or the other. So, I have one question, sir. Like, while using bevacizumab in ABCP, so which subset of patients you rule out, or like when do you start? Is someone presenting with hemoptysis and all?
Yeah, so if somebody has got a major hemoptysis or a cavitatory lesion which is close, I think hemoptysis is one, and if the lesion, so if you do a clinical trial, they say the lesion should not be close to the arteries, pulmonary arteries, and should be feeding over there. So anybody who has a significant hemoptysis history, and if it's a cavitatory lesion which is closer to the major vessels, we do exclude those patients. But typically in adenocarcinomas who have progressed on EGFR, you don't really get those. You get something which is very, very peripheral. Uncontrolled hypertension, cardiac comorbidities, urine for proteinuria is also something. A standard bevacizumab and a thrombosis. Thrombosis is something which I'm grappling with a lot with bevacizumab. And I don't know if what should I do when somebody gets a thrombosis and I put them onto rivaroxaban or something. How much to continue? Till now, I have not stopped. Except for a stage pulmonary embolism, I do continue them on bevacizumab along with DOACs or a Clexane.
Always someone presenting with mild hemoptysis.
Mild hemoptysis,
one or you wait?
No, so mild hemoptysis, you make sure there is no HB drop. Just to cover your medico-legal this thing. So what we do is we do a subsequent 2-day analysis. We write over there in our notes that there is no significant hemoptysis, there is no HB drop, and you give. Nothing happens.
From cycle 1 itself.
From cycle 1 itself. If there is no other contraindication of a cavitatory lesion close to the vessels and everything, streaky hemoptysis everybody will have. So if there is there's no life-threatening hemoptysis, either now or 6 months back, no HB drop, you can safely give. Obviously, you will take a consent with the patient, and then you can take it from there.
Thank you, sir. Thank you.
Thank you.
So we'll move on to the next session. Session sponsored by AstraZeneca. So I welcome Dr. Jyoti Anand. So she is a consultant in medical oncology at Yashoda Hospital, Delhi. Over to you, ma'am. So Dr. Jyoti, I think you're.
Hi, Dr. Trivitram. How are you?
Hello, ma'am. Hello. I'm good. How are you, ma'am?
After such a wonderful talk by Dr. Ulas Batra on non-small cell lung cancer, so now my responsibility is small cell lung cancer and definitely the role of immunotherapy in small cell lung cancer. So I'll start sharing my screen. Is my screen visible? Hello?
Yes, ma'am, it's visible.
Okay. So today we'll discuss evolving role of immunotherapy in extensive stage small cell lung cancer. So lung cancer, we all know it is the leading cause of cancer-related deaths worldwide. And out of that, small cell lung cancer, it represents 15% of all lung cancer cases. Though the proportion is very less, but mortality and the difficulties while treating such patients is very high. So most of the cases of lung cancer, that is 85% are non-small cell and only 15% are small cell. Followed by, if we talk about brain metastasis, which is a common site of metastasis in lung cancer, small cell lung cancer, approximately 50% of the patients, we encounter them with brain metastasis at the time of presentation. And most of the time it is actually a presenting sign. And median age of small cell lung cancer at the time of diagnosis is approximately 70 years. And it occurs exclusively in smokers, and 90 to 97% of the patients, they are smokers. So out of this 15% chunk, 2/3 of the patients, they are extensive stage small cell lung cancer at the time of diagnosis, and their life expectancy is less than a year if they are treated with EP alone, that is a standard of care, that is etoposide and platinum combination. So out of these 2 in 3 patients with extensive stage small cell lung cancer diagnosis, they have very poor prognosis if they take EP alone. The current first-line standard of care treatment, which is current first-line standard of care treatment. So we can see the survival rates are as low as 5.8% 3-year survival rates and only 1 to 3% 5-year survival rates. So this is our first-line treatment where we we have a lot of challenges if we are not able to extend the survival in first line. Very less number of patients are going for second-line treatment. So if we talk about the treatment advancements in small cell lung cancer, the standard of care, it was often given palliatively, is a standard combination of platinum, cisplatin or carboplatin with etoposide or irinotecan, and it had not changed since last 30 years. It was established in 1985 for first-line small cell lung cancer, followed by thoracic RT and limited disease, followed by topotecan, and then topotecan oral came into being in 2007, and then nivolumab for relapsed small cell lung cancer in 2018. Then atezolizumab came with combination of etoposide and carboplatin in 2018, and in 2019 we got the approval for durvalumab in combination with etoposide and any platinum, that is cisplatin or carboplatin. So this is again the spectrum of the treatment combinations what we have. In 1985, EP was established as the standard of care. Since then, many therapies have been unable to show meaningful improvement in patient outcomes, leaving EP as a standard of care for nearly 3 decades. Recently, emerging immunotherapies such as Durva have shown great promise and have the potential to change the treatment landscape. So this was the treatment combination: etoposide plus cisplatin or carboplatin. It is the current standard of care. IOs are emerging as first-line options. Combination EP 4 to 6 cycles. PCI and radiotherapy at physician discretion to prevent and treat brain metastasis respectively. And IOs have become available, durvalumab plus EP which got its FDA, EMA, and MPA approval, and it is NCCN category 1 recommendation also. And atezolizumab plus EP also, which has also got all the approvals and NCCN category 1 recommendation. If the patient relapses within 6 months, it is that is refractory or no response to first-line chemotherapy, we need to change the treatment to topotecan, lurbinectedin, or clinical trial. But if patient relapses after 6 months, we can re-challenge the same non-platinum chemotherapy or platinum re-challenge we can do for second line and beyond. So immuno-oncology products have replaced etoposide, cisplatin, carboplatin as a standard of care in first-line extensive stage small cell lung cancer. So cisplatin or carboplatin in combination with etoposide or durvalumab, carboplatin etoposide in combination with atezolizumab, or combination EP for 4 to 6 cycles. Sensitive or resistant response approximate if the first line therapy more than 6 months, then second line and beyond. So this in refractory cases, we don't use the same therapy. So this is the response rate. If we talk about first line EP, 60 to 70% of the patients initially respond to EP, and median PFS is 4.7 to 5.5 months, which all of us encounter that after first 3 cycles of EP, first reassessment, very good response. In after 6 cycles, completion of 6 cycles, second reassessment, patient has generally progressive disease. So this is what it is showing, that median PFS is 4.7 to 5.5 months. So resulting in a poor overall survival rate, median OS of 7 to 12 months only, and 1 year OS. Here we are talking about 1 year OS, that is approximately 40% only. So we definitely need newer treatments to improve the duration of response and overall survival for such patients. So using the most effective first-line therapy is critical to patient outcomes, as most patients receive only 1 line of treatment. So first-line therapy, approximately 80 to 100% of the patients are getting first-line therapy. Second-line therapy, only 30 to 50% of the patients are getting second-line therapy, and third-line therapy, only less than 20% of the patients. So we need to act here. We need a good first-line therapy so that more and more of the patients are able to receive second-line therapy. Although most patients, they respond to first-line atezo plus EP, they typically progress within 5.2 months. Their median PFS is, which is 5.2 months, and the overall response rate is 60.2%. So here we can see that at 12 months, the overall response rate was 52% versus 39% for EP. At 18 months, it was 34% versus 21%. And at 24 months, it is 22% versus 17%. So 2-year OS is approximately 22%. However, curves are trending towards convergence, and long-term survival benefit is uncertain. So it is towards convergence. So approximately 2 in 3 patients with extensive stage small cell lung cancer diagnosis, current survival data is limited to 2 years. We don't have data beyond 2 years. So longer treatment benefits are unclear, seeing the trial results or seeing the graphs. So 2-year survival rate is 22%. Now coming to Caspian trial, it is the first for durvalumab, it is the first and only approved IO in regimen in extensive stage small cell lung cancer to allow up to 6 cycles of EP in the control arm, and use of cisplatin or carboplatin, which was there not there in atezo trial. So for newly diagnosed extensive stage small cell lung cancer, WHO ECOG performance status of 0 or 1, with life expectancy more than equal to 12 weeks, at least 1 target lesion by RECIST 1.1. These were all the inclusion factors, and certification was based upon patients who received cisplatin or carboplatin. In induction phase, they were given durvalumab plus EP, investigator's choice cisplatin or carboplatin 4 cycles Q3 weekly, followed by maintenance of durvalumab 4 weekly until progression. 1:1:1 arm, 3 arms was there. 1 is EP arm, and the third arm was durva plus EP 4 cycles plus durva 5 cycles plus EP plus investigational agent, followed by durvalumab maintenance. And primary endpoint was overall survival, and key secondary endpoints are PFS, ORR, OS at 12 months, PFS 6 or 12 months, and of course quality of life. And Caspian trial, they also allowed for any platinum, which we have already seen, cisplatin or carboplatin, and patients who had asymptomatic or treated brain metastasis, both of such patients were allowed. And the control arm was allowed for up to 6 cycles of chemotherapy, and PCI per investigation's discretion was also allowed. So Caspian reflected international extensive stage small cell lung cancer clinical guidelines, which more closely aligns with how patients are treated with real world. So according to the clinical guidelines, cisplatin and carboplatin both were allowed. So use was left up to physician discretion. In IMpower 133, it was carboplatin, but in Caspian, use of either platinum was allowed. For brain metastasis, treatment of patients with symptomatic or asymptomatic brain metastasis, radiotherapy is recommended before or after systemic therapy, respectively. In IMpower 133, patients with brain metastasis were only eligible if they had received prior treatment. But in Caspian, they were allowed in either trend, like asymptomatic, untreated also, and treated also. According to international guidelines, 4 to 6 cycles of EP were recommended. But in IMpower 133, only 4 cycles of EP were recommended. And in Caspian, the patient can have 4 to 6 cycles of EP according to the result. So the Caspian trial, it was more in accordance with the clinical guidelines. So seeing the results of durvalumab plus EP, that is Caspian trial, now 3-year OS, we have 3-year OS analysis with us in Caspian trial, and median duration of follow-up was 39.4 months. If we see here, in EP plus durvalumab arm, the overall response rate at probability of OS at 1 year was 52.8 versus 39.3 months for EP arm, 18 months 32 versus 24.8, 24 months 22.9 versus 13.9%, and there is no convergence of tails. The tail is still going on, and we have still till date we have 3-year data also, 17.6% versus 5.8%. So almost 3 times the number of patients who are responding to EP versus 3 times patients who are responding to durva plus EP combination. So in if we see median overall survival, numerically you will not find much difference, but 3-year OS is definitely better as compared to EP arm. 12.9 versus 10.5, and the hazard ratio 0.71. So durvalumab plus EP, it improved the estimated percentage of alive patients 3 times as compared to EP arm. And we can see clear separation of curves that is sustained with a notable flattening, which was observed beyond 27 months. So if you see IMpower 133 OS 12.3 versus 10.3, numerically not much of difference, but if you see the tail of the curves, it is not flattening. There was no separation of the curves. But in durvalumab, Caspian 3-year OS, there was separation of the curves, and the curves are not converging. It is rather flattening out. Here is 1-year OS, comparatively 52.8 for durva versus 51.9 for atezo, 22.9 versus 22, and 3-year OS data is not available for atezo, though it is 17.6% for durvalumab. If we analyze the subgroup analysis, durva plus EP was evaluated in key patient subgroups reflective of clinical practice in extensive stage small cell lung cancer, and all the subgroups, they are favoring the use of durvalumab plus EP as compared to EP alone. So durvalumab is the first approved IO to improve both response rate 68% versus 58%, durability of response at 24 months, that is 13.5 versus 3.9% in extensive stage small cell lung cancer. If we see patients who had response at it is 67.9 in durvalumab plus EP arm compared to 58% in EP arm, and 24-month duration of response in Caspian trial is 5.1 in months for durva plus EP, and EP 5.1 months also. But at the end of 3 years, more than 3 times of the patients are responding as compared to EP alone. This is the difference. So durva plus EP, they demonstrated a sustained improvement. What we all want is sustained, slow, sustained response, which we are getting from immunotherapy, with nearly 4 times the number of patients progression-free at 24 months. So at 24 months, it is 2.9% versus 11%, with ongoing treatment for patients also with ongoing treatment at 3 years. So median PFS for durva is 5.1 versus 5.4 with hazard ratio 0.80. 9.1% of patients have been on durvalumab for more than equal to 3 years. 10.1% of patients were continuing treatment with durvalumab at the 3-year data cutoff. So OS based on baseline brain metastasis, if we stratify patients like that. So these are the graphs for patients who had brain metastasis. Median OS was 12 months for durva plus EP arm and 8.8 months for EP arm only. And patients who didn't have any brain metastasis, durva plus EP, median OS was 13 months versus EP 10.5 months. So though patient had brain metastasis or patient did not have brain metastasis, Durva plus EP is doing better as compared to EP alone. At 24 months, the overall safety profile. Now comes the in extensive stage small cell lung cancer or any treatment stateful cancer. What is important is side effect or quality of life related things also. So if we talk about toxicity profile of Durva plus EP, all grade toxicities, they are comparable as compared to EP arm only. 98.1% versus 97. Grade 3 to 4, 62.3 versus 62.8. Serious 32.1 versus 36.5. All adverse effects leading to discontinued treatment is 10.2 versus 9.4. And immune mediated toxicity was definitely higher here because there was immunotherapy, but there's no use of immunotherapy, so no immune related adverse effects. And adverse effect leading to death, it is also comparable. So rates of grade 3 to 4 adverse events, serious adverse events are numerically lower in Durva plus EP arm relative to EP. There are nominal differences in discontinuation rates due to AEs in either arm. And so majority of IM AEs are low grade, managed in line with standard treatment guidelines. At 36 months, there are no new safety signals. Whether there are any safety problems if patients are continued with durvalumab maintenance for 3 years, there were no new safety signals identified or significant changes in the safety profile demonstrating consistency in patient tolerability also. Febrile neutropenia, pneumonia, anemia, thrombocytopenia. So these are the most common side effects and they were easily manageable. So Durva plus EP delayed patients' time to deterioration in functioning and quality of life. The global health status, cognitive functioning, emotional functioning, physical rule functioning, they all favor the use of durvalumab over EP only. And Durva plus EP delayed time to deterioration in symptoms, including dyspnea, appetite loss, pain, fatigue, and cough. These are the patients, all subgroup, appetite loss, nausea, fatigue, pain, insomnia. So all are favoring Imfinzi plus EP over EP alone. So what is the administration schedule? Induction of 4 cycles, 3 weekly of durvalumab 1500 milligram fixed dose in combination with Ddpcr and platinum as per physician choice, followed by Q4 weekly. There is also one more difference, that is it is 4 weekly maintenance dose of fixed dose of durvalumab of 1500 milligram. And if we see about study design differentiators in Caspian and IMpower 133, so there was no biomarker selection. Untreated brain metastasis were excluded in IMpower 133, though it were included in Caspian. PCA was allowed in both the arms. PCA was allowed in experimental arm, but the patients were excluded, and up to 6 cycles of chemo was allowed in Caspian. So cisplatin was also allowed in Caspian. So Caspian study inclusion criteria is reflective of real-world clinical practice. It allowed treatment with either cisplatin or carboplatin, included patients with either asymptomatic, untreated, or treated brain metastasis, compared against up to 6 cycles of chemotherapy with optional PCI. So it is category 1 recommendation according to NCCN. Also, we all know Durva or atezolizumab in combination with EP. It is category 1 recommendation for patients, primary therapy for extensive stage small cell lung cancer patients. So the conclusion is, first line Durva plus EP has shown sustained improvement in OS compared with the robust control arm. That is reflective of a real world scenario by allowing up to 6 cycles of EP. Use of PCA was compared and as compared to the results from atezo plus Eto Carbo study of IMpower 133. Durva is the only IO that provides flexibility of choosing cisplatin or carboplatin alongside Ddpcr. Benefit with Durva plus EP was observed across all subgroups, include brain metastasis subgroup. More than 17% patients on Durva plus EP arm are surviving even after 3 years, showing prolonged survival benefit. Durva plus EP provided a high response rate and demonstrated ongoing responses at 2 years, 3 times more as compared to EP arm. Durva offers convenient once monthly dosing regime. That is also a convenient thing in the maintenance phase. And safety findings remain consistent with known safety profile of Durva and EP. Thank you.
Thank you, Dr. Jyoti, for highlighting the data in extensive stage small cell lung cancer. We all know that small cell lung cancer responds beautifully to chemotherapy, but the issue thing is the rapid relapse. So these newer agents helps in increasing the survival rates and duration of response. So thanks for highlighting this, ma'am.
Thank you, Dr. Ddpcr.
So moving on to the next session, sponsored by BMS. So I welcome Dr. Parveen Jain, Consultant Medical Oncology, Akash Healthcare Hospital, Delhi. Welcome, sir. Over to you.
Thank you. Thank you for the warm introduction. So I'll share my screen. So I hope my screen is visible.
Yes, sir.
1 second.
Make it full screen, sir.
Yes. So first of all, good evening to all. And I am here to present the long-term survival data of nivolumab in metastatic non-small cell lung cancer, and it is particularly in the second line setting or the pre-treated setting. So we already know about the non-small cell lung cancer. So that lung cancer, it is one of the most common cancer diagnosed as per the Globocan data, and it is the cancer with the highest mortality, and so that the lung cancer mortality, it surpasses the mortality associated with colorectal, breast cancer, and prostate all taken together. So in male subgroup, so 24% of all cancer death, they are due to lung cancer. So it is, so we can see over here that it is the leading cause of cancer death among men. And in fact, in women also nowadays, a lot of lung cancer is being diagnosed. And again, the mortality in women also, it is quite high as compared to other cancers. So there are broadly two type of cancers, lung cancer, small cell and non-small cell. I think we don't have to go into details of this. So regarding the stage distribution, only 16% of the patient, they present with the early stage lung cancer who are literally amenable for curative treatment in form of surgery and with or without chemotherapy. And almost 1/4 of the patient, they present with a stage 3 disease, which is quite a heterogeneous group. And the treatment varies from surgery followed by adjuvant therapy or CTRT followed by durvalumab based adjuvant immunotherapy. And coming to the stage 4. So stage 4, if we go back 2 decades back, so it was being treated as a like histology based treatment only. So but nowadays we have a lot of options. So we have to basically distinguish the oncogene driven tumor from the non-oncogene driven tumor, and almost all of these patients, they are amenable for some like individual patient based treatment. So regarding the lung cancer in India, so we do have a lot of lung cancers with 72,510 cases which are diagnosed every year, and with approximately 90% of death rate in the same year. So if we go to the second line treatment, so first line, it is a heterogeneous group. We have a lot of options. So, but with the availability of so many options in first line, so we also have to see, look for the second line therapy, because most of these patients, so they have good performance status after first line failure. And because of this, they are now candidate for, most of these patients are candidate for second line treatment. So initially, if we go back to early 2000s, so docetaxel was the first agent which was approved by FDA for second line treatment. And later on, in oncogene driven tumor, targeted therapy options were also there. And after that, there was a era where immunotherapy came into picture, and it was tried against docetaxel. All agents, they were tried against docetaxel. So nivolumab, pembrolizumab, atezolizumab, then all of them, they had shown good result and durable responses against docetaxel with reduced side effect as compared to the chemotherapy. So these are the factors which we definitely consider in selecting our treatment. So these are prognostic factors pertaining to performance status of the patient, then the smoking history, then the line of therapy, the previous therapies which patient had received, absence or of extrathoracic tumor at the initiation of treatment, or the response to the previous chemotherapy regimes. Then there are certain predictive factors like disease control after first line and second line treatment, then how the patient responded to the first line treatment, whether it was a rapidly progressive disease or it was a indolent sort of disease, because we have seen those people with indolent kind of disease benefiting more with immunotherapeutic approach, and those with a very rapidly progressive disease. So those are those patients where I think probably chemotherapy works better than immunotherapy in these patients. So then coming to treatment benefit and toxicities, the prior toxicity, whatever the patient is having, and what are the patient preferences. And one more factor which always come into picture in Indian context, that is the affordability of the patient. Because immune checkpoint inhibitor treatment, so it is quite a costly affair for most of our patients. So these are the treatment guidelines for non-oncogene driven tumors in non-squamous cell, non-small cell lung cancer. So initially they are treated with either chemotherapy or chemotherapy plus bevacizumab or chemotherapy plus immunotherapy or immunotherapy alone. And once they progress on this, so then the other options are the next line chemotherapy or immunotherapeutic approaches, depending on whether the patient had received it in prior lines or not. If we look for squamous cell, non-small cell lung cancer, again, similar kind of graph we can see over here. The only thing is that the maintenance treatment is not a validated one in the squamous non-small cell lung cancer. So coming to the outcomes of nivolumab in the second lines or later settings. So I'm here to present analysis, that 5 years landmark analysis of Checkmate 017 and 057. So which was nivolumab versus docetaxel in previously treated non-small cell lung cancer. And the proof of concept came from the Checkmate 003 trial, and recently this analysis was published in Lancet Oncology in 2019, and it showed, and this was with a follow-up of 6 years, and we can see over here that there were these durable responses which led to improved overall survival, and at 3 years almost 18.4% of the patients they were alive, and we can see down the line even after 6 years. So very minimal of these patients, they had progression and they had died because of the disease or some other causes, and most of the patients who surpassed 2 to 3 years of timeline, so they were alive even at 6 years of timeline. So coming to Checkmate 017 and 057 study design, so both of them, they had a similar kind of study design. The only difference was that Checkmate 017 was in the squamous non-small cell lung cancer, and Checkmate 057 was a prior like non-squamous lung non-small cell lung cancer, and 057 also selected those patients who had prior TKI therapy for oncogene driven tumors, and these patients were randomized into 1:1 fashion to nivolumab in the dose of 3 milligram per kg body weight or docetaxel at a dose of 75 milligram per meter square, and the therapy was continued till progression. There was no time point when the therapy was supposed to be on hold, and the primary endpoint of this trial was overall survival, and the additional endpoint were PFS, overall response rate, and efficacy by tumor PD-L1 expression, safety, and patient reported outcomes. So these all primary and additional endpoint, they were reported in the interim and the final analysis. But recently in 2021, so the landmark analysis that which was the 5-year follow-up, and there were some other exploratory analysis which were done. So I'm here to present those. So, and there was an amendment in this trial which had given the option of fixed dose nivolumab, fixed dose dosing. So that was either 240 milligram 2 weekly or 480 milligram 4 weekly was also an option. So this is the 5-year pooled overall survival, which was in favor of nivolumab, and we can see over here that at 1 year the overall survival was 48% versus 34.3%. But if we go down the line, So after 2 years, most of these patients, they were still alive at 5 years. And we can see that the overall survival was almost 5 times that of docetaxel in favor of nivolumab, with 13.4% of the patient, they were still alive in the nivolumab arm. And these were unselected population, irrespective of the PD-L1 status, irrespective of the histology of the patient. So if we see according to the PD-L1 status, we can see over here that the pooled overall survival in PD-L1 positive patient was even better as compared to the unselected population, and it was 5-year OS rate was 18.3% in nivolumab arm, vis-a-vis 3.4% in the docetaxel arm. But the thing worth looking at is that those patients who surpassed 3 years timeline, so they were 21.3%, and out of which only 3% had died in these 2 years timeline. So most of these patients, they can presumably be taken as either cure or long-term overall survivors is the term to be used for these patients. If we see the PD-L1 less than 1% or PD-L1 negative population, again, the overall survival rate at 5 years was 8%, but it was still in favor of nivolumab as compared to docetaxel, which was 2%. So according to the histology, if we see squamous metastatic non-small cell lung cancer, so we can see over here similar kind of graph which we saw in the unselected population, and almost 4 times overall survival rates at 5 years in favor of nivolumab as compared to the docetaxel, which was 3.6%. And in the non-squamous non-small cell lung cancer, so the benefit was even more in favor of nivolumab as compared to docetaxel, with 14% of the patients who were still alive at 5 years as compared to 2.1% patient in the docetaxel. And we had seen similar kind of graphs in the Checkmate 003, which we saw at 6 years, and almost 14% are the patients who live for more than 5 years. So here is the subset analysis, and we can see over here that almost all the subset, they had overall survival benefits in favor of nivolumab as compared to docetaxel based chemotherapy. So coming to the duration of response and the progression free survival, we can see over here that the 5-year pooled PFS was 8% in nivolumab as compared to 0% in docetaxel. So none of the patient, they had progression free, they were progression free at 4 years timeline. And if we see even at 3 years timeline, only 0.5% of the patient, they were progression free, vis-a-vis 8% of the patient, they were still maintaining the nivolumab response at 5 years. If we see the duration of response, again quite a amazing graph we can see over here, that almost 32.2%, that means almost 1/3 of the patient, they were still in response at 5 years as compared to 0% with the docetaxel. And moreover, if we can see here that the overall response rate was 20% with the nivolumab, vis-a-vis 11% with the docetaxel, and these 20% who responded to nivolumab, so these were those patients who had a very good overall survival and extended overall survival. And these are those patients in this graph who had complete or partial response. And you can see over here that the overall survival at 5 years was 53%. So those patients who develop some response with the nivolumab, see, these are those patients who maintain this response for a very long time, and almost 1/2 of these patients, they will be alive at 5 years timeline. So this was again a kind of analysis, so where they showed that 45 patients, they were progression free at 2 years, 29 were the patients who were progression free at 3 years, and 25 were the patients who were progression free at 4 years. And if we see these particular patients with 2-year progression free, we can see over here that 76% of these patients, they had progression free survival of 3 years. 68% of these patients, they had progression free survival of 4 years, and 60% of these patients, they had a 5-year progression free survival. And we can see over here that the overall survival in those with who were progression free at 2 year was 60%. Overall survival of 5 year in those patients who were progression free at 3 year were 93%, and all those patients who were progression free at 4 years, they survived for more than 5 years timeline. If we see the difference in the population who survived for less than 1 year vis-a-vis who survived for more than 5 years, so there were certain differences which they could make out. So one was those patients who survived for less than 1 year, so they had more PS1 patient and less PS0 patient as compared to those who were a long-term survivor who had more like better performance status patient. And in fact, those patients who had survived for more than 5 years, they had more PD-L1 positivity as compared to those who survived for less than 1 year. So coming to the treatment status of survivor at 5 years, we can see over here that 50 patients were those who survived for 5 years with nivolumab, out of which 21 patients they had progressed, and out of which 19 patients they received subsequent treatment. So this is again a very, very important thing to look at. So those patients who were survivor at 5 years, so most of them who progressed on nivolumab, they had received subsequent treatment. So they were probably in good performance status, and they were candidate for subsequent treatment also, which probably will lead to more overall survival advantage. And those patients who did not progress at 5 years, so out of those 5 patients, they were off nivolumab because of the treatment related adverse event, or they received maximum clinical benefit. And 16 patients, they were still on nivolumab, and 8 patients, they were censored. And if we see the docetaxel, only 9 patients, they were having 5-year survival, and out of which 8 progressed, and almost 100% of the patient, they received subsequent treatment, and most of them, they received immunotherapy as a subsequent treatment. So another thing to look at is the safety summary, because nivolumab, when it is being given for such a long period of time, so there are always safety concerns associated with such a long duration of treatment. So what they observed was that the most common toxicities related with nivolumab, they were either skin or endocrine toxicity, which were easily taken care of, and only few of the patients, they had grade 3 or 4 adverse events at 3 to 5 years timeline. And precisely it were these were the 3% of the patient had grade 3-4 events. So this suggests that there were no new safety signals which were noted when nivolumab was used over a very long period of time. So to summarize, in a pooled analysis of 2 phase 3 trial stopped early due to superior overall survival, and the nivolumab delivered 5 times the OS rate at 5 years, and the OS benefit was seen across all subgroup and patient achieving a response. These were specifically those patients who had the best overall survival advantage with nivolumab, and there was improved overall survival across PD-L1 expression level and histology. The patient without disease progression at 2 and 3 years after treatment with nivolumab had a 60% and 78% chance of remaining progression free at 5 years. At 5 years, 10% of nivolumab survivors, they were off study drug, and they had not progressed and had not received any subsequent treatment. And with 5-year minimum follow-up, there were no new safety signal which were identified for nivolumab. So there was no evidence of late onset grade 3 or 4 treatment related adverse event. So with this, I would like to end my talk. If there are any questions, I think I'll be happy to answer those. Thank you.
Thank you, sir. Thank you, Dr. Praveen. Thank you for presenting such exhaustive data in a very easy and lucid way and highlighting the survival data of nivolumab. So thank you, sir.
Thank you.
So are there any questions? I think today's festive season, I think that's the reason the participation is dwindling. So anyway, I think if there are no questions, I think we can wind up. So I thank all the speakers and the participants and listeners and the organizers, especially Mr. Tarun and team, Ms. Pooja, Ekta, Garima and all, for making this event successful. I also thank my sponsors, AstraZeneca, Roche, Intas and BMS for supporting this event. So over to you, Pooja or Ekta, like to organize.
Thank you, sir. Thank you everyone for joining and for this academic feast. And thank you our academic partners, AstraZeneca, Intas and Roche. Good night, everyone.
Good night.
Thank you, Pooja. Thank you, Garima.